All right, so I thought I was going to present a case that made me think a little bit and was going to pimp a lot of folks in the front, but in the spirit of sort of keeping the time, I will just do the talk and then we can discuss during the question and answer session. All right, so here's the case. So chief complaint is hunched over and pain went with ambulation. 32-year-old gentleman who's presenting to my clinic with the scoliosis evaluation. Worsening symptoms noted either 6-7 years ago. Scoliosis surgery was actually done at 15 years of age at an outside institution by a guy who does a lot of scoliosis surgery, a very reputable, known to be an excellent surgeon. Over the past several years, he's becoming more and more hunched over and having difficulty ambulating. Despite that, he's actually a full-time worker as he's a janitor. And he describes having more back pain than leg pain. And there's fatigue with the upright posture and ambulating. Classic sort of sagittal balance issues. Has a history of neurofibromatosis, one with scoliosis, and has surgery. Otherwise, a very upstanding citizen, healthy, young. Significant for forward pitched posture, walks with pelvic retroversion and knee flexion, holds himself upright. He has a large right thoracic prominence, well-healed surgical scar, no neurologic findings. He's essentially normal. So this is what it looks like in the clinic. And you can see the scoliosis. And he's, maximally extending his neck to stand upright. And this is what he looks like when he's laying down. You can see the rod sticking out there. It's rigid, nothing's moving. And, the prone view on the left side is at in the examining room, and the prone view on the right side is in the operating table with fully generally relaxed and James may say that you may gain 8 degrees of lordosis just by laying the patient, but in this case, everything's fused and stuck. These are X-ray findings, scoliosis and kyphosis. He does have fairly even shoulder and pelvis. So I am an open surgeon. I guess I'm the minority here. And these are some of the patients that I see, and that, looking at this, you can see that he's globally fairly well balanced, right? The head is right over the center of the pelvis. So he's complaining symptomatically, mostly in the sagittal profile. He's still young, so he's able to fight the gravity and maintain a upright stance, but he does get fatigued. I'd like to get supine films, or if you cannot, when you are obtaining CT and or MRI, those are done with the patient laying supine on the exam table, and then you can actually appreciate how much flexibility there is, right? So when you're doing sort of corrective surgery, there are curves that are flexible, there are curves that are relatively stiff but not entirely fused, and there are those who are absolutely ankylosed, and your surgical plan changes depending on the flexibility of the curve. And this is one way of figuring out how flexible the curve is. Is there a way to run the videos from the back? These are CT scans. And then you can click on the sagittal ones also. So you can see that, he's absolutely fused all over the place down to the pelvis. The L5S1 disc space has some gapping, but posteriorly he's absolutely fused. And I guess you can also appreciate the bony changes, right, from the dural ectasia. And you go to the next slide. So I guess these are some of the select cuts. So I was planning on getting some anchor points, and those are lumbar pedicles, and then the sacral pedicles, and the pelvis is thankfully relatively normal. You run the videos for the MRI. These are T2 cuts of the axial and sagittal profiles of the spine. You can One thing that you don't have to worry about this patient is stenosis, right? So it's wide open. There's no shearings or any abnormalities within the neural tube. So that was one thing that I didn't have to worry about. Let's see, these are lower sort of MRI cuts. Let's see, these are axial cuts, thoracic and lumbar. So there's a significant dural ectasia with worn out bone. And I've done, NF1 scoliosis surgery, but I have not done a 3-column osteotomy, before this case. So, this case got me quite worried. A 32-year-old male with positive sagittal imbalance, back pain with ambulation, had scoliosis surgery, completely fused spine, neurologically intact. So the consideration for me was there's significant deformity that I have to address. The monkey wrench in this case is that despite the scoliosis, his coronal balance is perfect. And he has clinical and more sagittal issues. There's massive fusion down to the pelvis. And instrumentation becomes an issue. There's a broken rod, obviously, dural ectasia, small pedicles. So I guess I'm going to just go ahead and present what I did. So this is an open surgery, no MIS. If you are used to seeing droplets of blood, just close your eyes, okay? So we had to remove the previous instrumentation, place bilateral iliac screws, and I'm an open surgeon, so I don't use a whole lot of fluoroscopic images, thankfully for myself and the patient, but I do damage a lot of muscles, I guess. In this case, maybe a couple of times a year, I do use a 3D imaging and navigation, which are quite useful when there's fusion mass and nothing else. For lumbar pedicle screw instrumentation, ended up doing L3 and L4 asymmetric pedicle subtraction osteotomy, right? So I had actually one good L5 pedicle screw that was previously used. So I wanted to use that as an anchor point. So I went one level up because of the severity of deformity, in the convex side, I just needed to take out one pedicle, but on the concave side, you had to take 2 to make it even. And then the bony cut, I needed to preserve his scoliosis, which is very contra to what my brain was telling, because his coronal balance was perfect. So I had to preserve his scoliosis, and that meant that I actually had to make the bony cut horizontal to the ground, sort of along the iliac crest line. And then, obviously you're going to get a dural leak. And this is one case so to date in which I counsel the patient, if I actually encounter no dura or massive CSF leak, I'm going to abort the case. And I was, the happiest moment during the case was that I actually found dura. It's like, it was crappy, it was very thin, but there was dura. So that got me very sort of happy during the middle of the case, telling the fellow, yeah, this became from spine 501 to maybe 301, and was able to repair it and did a revision surgery, and I sort of left the room and the plastic surgeons took care of the rest. All right, so this was the bloody part where you have to close your eyes. So you can see that the bony cut was done obliquely, sort of horizontal to the ground. And my neurosurgery colleagues were telling me, if you get massive CSF leak, you can get a subarachnoid hemorrhage and you can kill the patient. So what am I gonna do in that case? I got a couple durotomies. It was, clearly sort of flowing. So I tamponaded like crazy with cottonoids and stopped the CSF leak. And I guess in the lumbar spine, the neural elements can take a lot more. Probably in the thoracic spine, I could not have tamponaded as much. And then put 2 bilateral iliac screws and close down. And then the fusion mass is very thick, so you can actually use hooks directly on the fusion mass and compress down on the hooks instead of the pedicle screws so that you don't loosen your anchor. And there's a ton of bone that you can use as autograft. So a lot of times I use, BMP posteriorly for deformity cases, but in this case, I decided not to because there was so much bone. And then I was able to close down the osteotomy site, literally bone on bone, and then sealed it and with the alloderm underneath so that the leakage was tamponaded. And I sealed it with the DBM putty that sort of acted like a glue. I know that there are other bone graft products that you can sort of shape and mold. So that worked out in my favor. And this is immediate pre-op and post-op. And patient was a little bit off to the left side. But 3 months later, the guy comes back standing upright, able to sort of function better and going back to work. And this is his scar. So the plastic surgeon did a nice job, and these are 3 months follow-up. He's about half a year out. So we could discuss about massive durotomy, repair techniques, how to sort of find anchor points, previous fused spine, et cetera, later on. Thank you.
Thank you.